Hello everyone, this is Warapon from Thailand. It's my great honor and pleasure to be part of Indonesia Retinal Specialist Society virtual event of this year. Today I'd like to talk about alternative imaging modalities in PCV diagnosis, especially when ICGA is not available, and the current management of PCV. And here's my financial disclosure. PCV is an important cause of central visual loss in aging populations, especially the Asian or African descendants worldwide. Clinical presentation of symptomatic PCV in clinic can be categorized into two forms. The first presentation, either serous maculopathy or serous maculopathy with lipid exudates. This presentation was due to leakage of the lesion. And sometimes spontaneous rupture of the lesion happened, so the patient presented with minimal submacular hemorrhage or extensive subretinal hemorrhage and sometimes breakthrough vitreous hemorrhage. So this presentation of PCV can mimic many other retinal diseases, including central serous chorioretinopathy, typical neovascular AMD, and many others. The gold standard investigation to diagnose PCV is ICGA. However, ICGA is invasive, time-consuming, and most importantly, it is not available at many retinal centers. For example, in Thailand, more than half of the retinal centers across the country do not have ICGA. So if PCV is an important cause of visual loss for our patients, but we do not have ICGA readily available, what are the alternative imaging modalities to help diagnose PCV? Today, I would like to focus on the use of color fundus photography and OCT, which I believe these are available in most clinics and really helpful for PCV diagnosis. Clinical features on fundus examination that's suggesting PCV diagnosis rather than AMD, including the presence of subretinal orange nodules, fibrovascular PED, massive subretinal hemorrhage, peripapillary location of the lesion, and no large drusen in the fellow eye. If a patient presented with submacular hemorrhage in one eye and you suspect the cause of neovascular AMD, that is the advanced stage of AMD, so the fellow eye should at least present of the early stage or drusen. But if the fellow eye show absence of drusen, so we should think of something else, not AMD, but we should think of PCV or some other diseases. On OCT, the typical characteristic of PCV, including the signs of polypoidal lesion. So you can see the border of PED will be sharp peak PED, or sometimes it has the notch on the cross-section OCT. And you can see the hyperreflective ring underneath the PED in some eyes. Signs of branching vascular network, including the presence of double layer site or the thin separation between the RPE and Brooks membrane. Sometimes we can see pachychoroid or thick choroid, but not always. Here is a case example. A 77-year-old Thai man presented with massive subretinal hemorrhage in the right. The fellow eye showed no large drusen and unremarkable findings. OCT across the lesion show multiple notch PED with a suspect hyperreflective ring inside, so we think about PCV diagnosis in this case, even before we have ICGA results that confirm PCV diagnosis. So it seems possible to make the diagnosis of PCV even before we have ICGA results. So at that time in 2016, we did the literature review and found that there were only very few OCT studies suggesting the way to diagnose PCV without ICGA. But in our opinion, in real practice, in addition to OCT information, we typically have fundus examination information, and sometimes we have FFA available. So we conducted this study to determine the sensitivity and specificity of diagnostic features on color fundus picture, OCT, and FFA to diagnose PCV without ICGA information. This study already published in JAMA Ophthalmology 2019. This was a retrospective imaging review including 120 people diagnosed with serous or serosanguinous maculopathy who underwent complete 4 types of images before they received any treatment at Chiang Mai University Hospital in Chiang Mai, Thailand. The 4 images including color fundus picture, OCT, simultaneous FFA, and ICGA. After the identification, the images were categorized in 3 sets without ICGA and were sent to 3 retinal specialist graders. And the grader have to take a look at each image and give an answer whether they see diagnostic feature of interest or not. In parallel, the other 2 retinal specialists confirmed PCV diagnosis using ICGA according to Everest criteria, and the results of 2 groups were compared. Here are the fundus characteristics that the grader reviewed. These are the signs that I presented earlier. For OCT, the grader looked at each feature on OCT, including presence of PED, sharply peaked PED, PED notch, hyperreflective ring, and double layer site. And for sharply peaked PED, because the previous literature does not provide the definite definition of sharply peaked PED, so this study we propose the angle between 70 to 90 degrees is called sharply peaked PED. We also look at the features on FFA, including classic or occult CNV, peripapillary location of the lesion, multifocal lesion, and typical Sesi leakage. Results from 124 eyes, 52% were PCV, 10% typical neovascular AMD, 36% CSC, 2% were other diseases. In this study, we would like to look at the AUC or area under the rock curve, which telling us how well a parameter can distinguish between PCV and not PCV group. Perfect score is 1, so we prefer 0.8 or higher AUC. For fundus feature, only 1 feature met 0.8 criteria. For OCT features, we found 5 features met 0.8 criteria, and none of the FFA feature met 0.8, so it seems that FFA provide relatively lower accuracy to detect PCV comparing to color fundus picture and OCT. Then we come up with the 4 highly suggestive features using logistic regression model, and we call these 4 features as major criteria. And the 4 features including 1 from fundus picture, which is the notch or hemorrhagic PED, and 3 features from OCT, including sharply peaked PED, PED notch, and hyperreflective ring underneath the PED. The other signs on fundus photography and OCT can be called minor criteria. And then we did further analysis to find whether we can increase the accuracy when more than 1 major criteria were found. And we found that if at least 2 or 4 major criteria, we will get highest accuracy, which is 93%, with 95% sensitivity and 95% specificity. If we found only 1 major and 2 minor criteria, the accuracy will drop to 52%, which is not satisfied. So this study suggests that when you found at least 2 of 4 major criteria, you will get 93% accuracy for PCV diagnosis. And we also found a predictive positive value of 92%. This can suggesting that if a patient presented with at least 2 of 4 signs, 9 out of 10 patients will have PCV diagnosis. Now let's take a look in details on each criteria. The first criteria is the notch or hemorrhagic PED or fibrovascular PED. This one, you can see the fibrovascular PED with and without hemorrhagic level inside. So all 4 eyes showing on this screen met the criteria. The next criteria is sharply peaked PED with an angle between 70 to 90 degrees. So we can scroll and look through each B-scan OCT and see whether the angle of the border is 70 to 90 degrees or not. For example, this PED, the border I think is approximately 80 degrees. And this one nearly 90 degrees. And this one approximately 70 degrees. Another feature is PED notch or multilobulated PED. So you can see at the B-scan OCT and see the surface of the PED has a notch. It can be 1, 2, or 3 notch. It doesn't matter how many, but if the notch present, then it met criteria. And the last feature is hyperreflective ring underneath the PED. So it can be the big ring like this one, smaller ring like this one, or very tiny ring like this one. And we just scroll through each OCT scan, and if we found the ring feature for only one scan, and then it's met criteria. Remember that according to our results, we need at least 2 or 4 major criteria. Now let's take a look at the case example. The first case is a 56-year-old Thai man presented with blurry vision in the right eye. Fundus examination shows serous maculopathy, and we can see the fibrovascular PED and OCT across the lesion show typical characteristic of PCV, including the sharp peak PED, hyperreflective ring, and double layer sign. And this case matched 3 major criteria, suggesting PCV diagnosis, and later ICGA confirmed the diagnosis. Now move to another case, a 67-year-old Korean male presented for diabetic retinopathy screening, but we saw subretinal hemorrhage and maybe PED near the optic disc. So we performed the OCT scan across the lesion. We found subretinal fluid and also PED with tiny ring inside and also PED notch. So this case matched 2 major criteria, and we suspect PCV. So the patient underwent ICGA angiography, and here's the results. So you can see pulsatile polypoidal lesions on ICGA, and pulsatile polypoidal lesions is the poor prognostic sign, and of course confirm the PCV diagnosis. Here's another case, a 65-year-old Thai man presented with blurry vision in the left eye. Fundus of both eyes shows confluence drusen, and also subretinal hemorrhage in the left eye. OCT show shallow PED with notch PED appearance. There were no sharply peaked PED, but there were multiple intraretinal cystoid change. So this case met only 1 criteria and doesn't suggesting PCV diagnosis. ICGA showing perfusing retinal arteriole and draining retinal venous from the lesion. So the final diagnosis is retinal angiomatous proliferation or RAP. And here's the last case, also presented with massive subretinal hemorrhage in the left eye, and the appearance of the hemorrhage, actually it's the notch hemorrhagic PED. The fellow eye was unremarkable without drusen. OCT across the lesion showed double-layer signs with subretinal hemorrhage. We also found sharply peaked PED and notch PED. So now we have three major criteria for this case, and think about PCV diagnosis. And later, ICGA confirmed PCV diagnosis. So these were our findings that were published in JAMA Ophthalmology 2019. And recently in 2021, Dr. Jamie Chung and the APOIS PCV work group have published this paper in Ophthalmology Journal. So this paper proposed the nomenclature for PCV and also the non-ICGA diagnostic criteria, and the criteria suggesting that the combination of three OCT-based major criteria, including sub-RPE ring-like lesion, sharp peak PED, and on-fast OCT complex RPE elevation. If you found all three features, you will get accuracy 90% for PCV diagnosis. And the on-fast OCT feature defined as the presence of hyperreflective branching vascular network connecting multiple PEDs. The on-fast OCT image can be obtained from Zeiss Spectral Domain OCT, but it's not available in Heidelberg Spectral Domain OCT, and it is available for most OCTA machine. So if on-fast OCT image is available in your clinic, these criteria can be another good option to diagnose PCV when ICGA is not available. Now let's move to the treatment for PCV. So the goal for PCV treatment is to maximize visual outcomes and also reducing treatment burden. So currently, treat and extend regimen is one of the most popular treatment regimens for retinal physicians across the world. And recently, Planet also published the year 2 results in 2019. According to Planet's study design, at week 12, the patient was randomized into two arms. The first arm received aflibercept Q8 monotherapy. The other received aflibercept Q8 plus rescue PDT. After year 1, if the patient did not meet the rescue criteria, the physicians have an option to switch to treat and extend in year 2. And here's the results. So for the x-axis showed visual improvement from baseline, and you can see that after the first 3 aflibercept injection, the visual improvement is rising and then maintained to about 10 letters in the first year. And in the second year, when treat and extend was applied, the visual improvement still maintained to about 10 letters. Regarding mean number of injections, in year 1, aflibercept monotherapy group received 8 injections on average, and in year 2, it reduced to 4.6 on average when treat and extend was. And they found that approximately 40% of the patients can have injection interval of 12 weeks or longer among those who apply treat and extend. And if we look at the visual improvement outcome, on the right-hand side, you can see the chart that patients who had at least 12-week injection intervals can still maintain at least 10-letter improvement on average from year 1 through 2 years. So in conclusion, the 2-year data from Planet demonstrate that aflibercept monotherapy is non-inferior to aflibercept with active rescue PDT. More than 80% of the patients require no rescue PDT, and treat and extend was allowed in year 2 of Planet participants, and they found that 40% of the patients can have injection interval of 12 weeks or longer in year 2, and Regarding visual outcome, treat and extend in year 2 did not decrease visual outcome at all, but most of the patients can maintain visual improvement approximately 10 letters in the second year. Thank you very much for your kind attention.